Good morning. My name is Rowena Jacobs, and I'm a professor of health economics at the Centre for Health Economics at the University of York. I think we can all agree that 2020 was an unprecedented year, especially so for the NHS and for mental health. These are two areas of research that have been at the heart of my work as an economist, utilising big data analyses to try to understand how the NHS can best care for people with mental illness. Research which will become likely all the more important once the impact of lockdowns and social distancing and other restrictions on mental health become clearer. So today I pose you this question: how can we best care for people with severe mental illness in the NHS? And by severe mental illness, we mean people with schizophrenia, bipolar disorder, or other psychoses. Let me start by posing another question. Do you know which illnesses cost the NHS the most to treat and which are the most costly to society? This chart covers the previous decade, 2003 to 2013, and divides all NHS expenditure into 23 disease categories. And we can see that mental health disorders are the single biggest area of programmed expenditure in the NHS, amounting to just over 12% of the entire NHS budget over this period, much bigger than cancers or diseases of the heart or lungs. Now, while more recent data like this of NHS spend by disease category is no longer collected in this format, mental health still remains the biggest category of spend at around 12 to 13%. So mental health disorders cost the NHS the most to treat. But of course, the impact of certain illnesses don't just fall on the NHS in terms of treating people. Mental health, unlike physical health, is not an illness that affects predominantly older people. It can also affect people of working age. So it can have a relatively larger impact on things like employment rates, welfare payments, lost tax receipts, sickness absence, lost productivity, and of course, people's quality of life. The economic and social cost of mental disorders is estimated at around £119 billion a year in 2020. That was preceding the COVID outbreak. And that includes health spending of around 20 billion, output losses of around 36 billion, and the impact on human capital at 69 billion. So to put this into perspective, the total NHS budget for 2020 was just over £130 billion, and the UK government spent around £92 billion on education. So this gives an estimate of the relative scale of the impact of mental illnesses on the economy as a whole at nearly £120 billion. So mental health therefore carries an enormous economic and social cost. And we also know that by far the biggest impact on the total cost, so more than half of that, comes from the estimate of the human cost and the impact on people's quality of life. For example, not being able to do the things they want to in their lives, such as engaging in learning or going to the cinema or the pub or the gym, or indeed experiencing stigma or discrimination, all of which have an economic cost. So within mental health, severe mental illnesses have a particularly large impact. The economic and social costs for these conditions are estimated at about £20 billion, so it's about 17% of the total economic and social cost of all mental health. Severe mental illnesses have a prevalence of around 1% of the general population, although they are disproportionately more prevalent in more deprived populations. And a key factor is that life expectancy of people with severe mental illness is reduced by as much as 20 years compared to the general population. This is the life expectancy that the general population experienced in the 1950s and remains one of the greatest health inequalities in the UK. So this difference in life expectancy is often referred to as the mortality gap. And the reason for this gap is that people with severe mental illness are often as much as 3 times more likely to have a physical health problem. And particularly in younger age groups, people with severe mental illness have a much higher risk of things like obesity, diabetes, and hypertension compared to the general population. People with severe mental illness are also much more likely to experience multiple physical health conditions, or what we call multimorbidity. So this means really a double whammy, a mortality gap and a morbidity gap. Indeed, the majority of these premature deaths in people with severe mental illness are caused by potentially modifiable health risk behaviors, such as tobacco smoking, where we see much higher smoking rates among people with severe mental illness, along with alcohol and addictions, lack of exercise and obesity, and various social factors such as poverty, homelessness, and unemployment. So what's being done to tackle this problem of the mortality and the morbidity gap? Let's return to our opening question. How can we best care for people with severe mental illness in the NHS? And this is a problem which has been vexing policymakers and health services for many years and continues to do so. In fact, a very large proportion of care for people with severe mental illness actually happens in primary care with GPs. And indeed, a third of people with severe mental illness are exclusively looked after by their GPs. And then GPs in turn are responsible for looking after the physical and mental health needs of their patients and coordinating care with other specialist services. So policymakers have put in place various mechanisms to pay GPs to ensure they provide good quality care. And GPs have set quality targets for a number of indicators for people with severe mental illness. The question is, are these financial incentives to provide good quality care and reduce the mortality and morbidity gap actually working? So with colleagues at the University of York, we set out to examine whether quality improvements in primary care could actually reduce morbidity and mortality and resource consumption. And we assessed the quality of care for primary care for people with severe mental illness using 3 indicators. First, whether they document a care plan for their patients, and this should cover the patient's health and social care needs and how these are to be met, as well as coordination arrangements with hospital and community mental health services, and their preferences in the event of a relapse. Secondly, whether they conduct an annual physical review of the patient's health, and this in turn should cover things like the use of alcohol and drugs, smoking behavior, and various checks for blood pressure, cholesterol, body mass index, and diabetes. So these 2 measures have financial incentives attached to them. But there could, of course, be other measures of primary care quality which also matter to patients and that are not currently included in the payment scheme. So by listening to patients, we added another quality of care measure which people with severe mental illness told us was very important to them, namely continuity of GP consultations. So basically seeing the same doctor on multiple visits to the practice, which of course can help foster trust between the GP and the patient. So we then set out to examine whether there was a link between quality of primary care for people with severe mental illness and a number of important outcomes. These included fewer emergency hospital admissions, preventable admissions, A&E department attendances, and premature deaths, as well as reduced re-entry into specialist mental health services and lower costs for people with severe mental illness in primary and secondary care, as well as community mental health services. Of course, for some patients in some circumstances, a hospital admission or indeed specialist mental health care may not necessarily be inappropriate or a signal of a poor outcome. But in general, it's reasonable to assume that this type of utilization should be avoided when possible. So our underpinning assumption here is that high quality primary care may prevent the need for additional healthcare and lead to lower resource consumption. Establishing a link between primary care and better outcomes proved a hugely complicated task. It required the collation and analysis of really big data sets across multiple sectors. And so for the first time in England, we linked data across the full patient care pathway to track the patient journey from GP surgery to A&E to hospital mental and physical health care to specialist community mental health services. And because of the complexity and the scale of the data and the linkages and the nature of the research questions we were asking, we needed to employ really advanced statistical methods to try to unpick the order in which events occurred across a patient journey so we could accurately assess whether it was indeed activities in primary care that were reducing subsequent morbidity, mortality, and upstream resource consumption. And we also needed to painstakingly cost up every activity that patients experienced in each of these sectors over multiple years to understand the financial implications. So what did we find? Firstly, care plans are associated with a 26% reduction in A&E presentations, a 33% reduction in mental health admissions, and a 27% reduction in preventable admissions. And they also reduced overall costs per patient per annum by £53. Annual physical reviews were associated with a 20% reduction in A&E presentations, a 25% reduction in mental health admissions, and a 24% reduction in preventable admissions, and in turn reduced overall costs by £34 per patient per annum. So now if we compare the financial payments made to GPs to provide these activities with the reductions in costs which we found in our study, we found that for care plans, for example, the reduction in costs was around 11 times as large as the incentive payments made to GPs. So the net savings for NHS expenditure is around £79 million in today's prices. And we can make similar calculations for annual physical reviews, although because they were associated with smaller reductions in total cost, the net cost implications are less dramatic. High GP continuity was associated with an 11% reduction in A&E presentations and a 23% reduction in preventable admissions, and were also associated with lower primary care costs. So what has our research revealed, and in particular, what can policymakers learn from it? Firstly, better quality primary care can improve outcomes for this vulnerable and often marginalized population. And our results confirm the value of processes enshrined in current incentive schemes. Care plans and annual reviews function as good quality indicators for people with severe mental illness and are really worth paying GPs to do. Our results also suggest continuity of care is an important indicator. In particular, seeing the same GP over time can improve the physical health of people with severe mental illness. So higher continuity may reduce the risk of preventable admissions through improved management of physical health by facilitating familiarity, communication, trust, and quality of relationship between doctor and patient. Of course, introducing this measure as a target and paying for it can be really difficult to implement. And indeed, current changes in UK general practice mean that continuity is likely to probably decrease rather than improve, particularly with things like practice closures, formation of practice networks, increasing use of locums, and of course, under COVID, speed of access taking precedent over continuity. So this means that practices really need to prioritize continuity of care for this patient group, despite the challenges in doing so. Still, not every patient receives a care plan or a physical health check, and despite these available incentives. And so the morbidity and mortality gap remains, and indeed, there is even evidence of it potentially increasing. So policymakers are now seeking new means to address this, including incentive schemes within hospitals to undertake physical health checks and additional incentives for commissioners of mental health care. So we're currently undertaking further work for policymakers to better understand who receives physical health checks and how these can be incentivized and potentially targeted. Also, a number of individual indicators within the annual physical review have also been dropped, BMI, cholesterol, and blood glucose, and policymakers are now looking to reinstate these again. So the evidence from our work is feeding into these decisions on the design of these incentive schemes. Our current work is also helping policymakers and practitioners understand the relationship between severe mental illness and multimorbidity, since services are currently really geared up to treating individuals either for their mental health problem or their physical health problem. And this dualism remains a real challenge for health services to manage individuals in a more holistic way. And understanding these disease clusters and risk factors and care pathways and outcomes for people with these co-occurring multiple long-term conditions will require even more big data, complex data linkages and smart analytics, so we can continue to help to understand how best to care for people with severe mental illness. And the techniques and advanced statistical methods we've developed in this research project at the University of York provides a really powerful platform for helping the NHS, both policymakers and practitioners, to overcome the damaging morbidity and mortality divide caused by severe mental illness. I'd like to acknowledge the many contributors to this work and the fantastic teams I work with. Thank you.